So yeah, today's presentation is about electrocardiogram interpretation. So first of all, what we have studied from our first year of pharmacy background, right? That how does the electric impulse gets generated in the heart. So first of all, we have just come towards all the viva. We are giving viva towards our professor in first year, second year, basic anatomy class. So this is the scenario which we are always mugging up, that it starts from the SA node, AV node, bundle of waves, bundle branches, Purkinje fibers. Yeah, this is the stuff which we are always mugging up. But the thing is that, as you can see my cursor here, so from here, there is SA node, right? So electrical impulse travels from SA node to AV node here. This is the AV node here, right? Bundle of His. These are the bundle branches and down to the Purkinje fibers, right? So this is the basic stuff which we all are knowing. But there is certain subdivisions further divided. As there are some students who have been joined here and they have already attended today, like my 6 week session which I am running about ECG, right? So yeah, this is the basic scenario. So SA node, from SA node to AV node, the impulse is getting generated and travels from SA node to AV node, and from bundle of His, from AV node to bundle of His, and bundle of His to Purkinje fibers. So during that stuff, there is bundle branches. There are bundle branches located, and bundle branches are further subdivided into two parts: left bundle branch and right bundle branch. Further down, left bundle branch is subdivided into left anterior fascicle part and left posterior fascicle part, and down to the Purkinje fibers. This is something new, as everyone have not heard about this. But yeah, this is the thing which we have to know as we are studying this ECG. So impulse is the main stuff which we are about to know, that how it is getting generated, right? From SA node, once again with me, from SA node to AV node, right? From SA node to AV node, little bit of pause is there. Bundle of His, bundle branches. Which bundle branches specifically? Left and right. And which are the valves present?
Tricuspid.
Where?
Tricuspid in between right atrium and right ventricle, and bicuspid between left atrium and ventricle.
And what about mitral valve? Okay. Bicuspid valve is also known as mitral valve. Okay, got it. So the thing is that during this time the impulse is getting traveled from SA node to AV node, and during this time there is contraction in the atrium. So due to the contraction in the atrium, there is generation of P wave. What? The generation of P wave, right? So as you can see that in ECG, when you are seeing this stuff, right? If any kind of abnormality in the atrium is there, in the atrium, right? In the atrium is there, then you have to always see for which wave? Look for P wave, right? Any abnormality is there, right? Look for P wave, right? Now coming down towards the vent, the impulse get generated towards the AV node, right? If the impulse is getting traveled towards the AV node, when the impulse is getting traveled towards the AV node, right? And during that time, there is little bit pause. The delay is there. Specific delay for 2 to 3 seconds, not more than that, right? So that delay gives the generation of PR interval, right? When there is contraction in the atrium, the P wave is getting generated. When the impulse is plotted, right? So after that, the impulse is traveling towards the ventricle. So remaining waves are QRS segment, right? So during that time, the impulse is at the ventricles, these both the chamber, right and the left, right? So QRS waves are getting generated, right? And when the impulse is getting away from the ventricle, means the relaxed phase is coming, relaxation phase is coming. We'd also say that this is the phase of repolarization. During that time, the ventricles are relaxed, right? The ventricles are relaxed. So ST segment waves are generated, generally T waves, right? So which is the point that AV node, at AV node, when PR interval is getting generated, during that time no chamber of the heart is getting contracted, right? That is the relaxation phase for 2 to 3 seconds. 2 to 3 seconds, right? This is the basic understanding of ECG which we all have studied. So the thing is that uh, the impulse is traveling from SA node to AV node. Here it is like this. So SA node to AV node, little bit pause and down. SA node to AV node, little bit pause and down towards the ventricles. SA node, AV node, little bit down, down towards the end. This is the video which I have created. See, P wave due to the contraction of atrium, and after that there is relaxation phase, like from the atrium. When atrium is getting relaxed, right? When atria is getting relaxed, during that point, PR interval is getting generated. Yeah, the PR interval is getting generated. After that, when the impulse is traveling towards the ventricles, during that point, QRS wave is getting generated. QRS segment, right? When the impulse is getting away from the ventricle, means the relaxation phase comes, then ST segment wave is getting come. So the thing is that if we want to count the heart rate of a person, then during that phase, we just see the RR segment. RR segment, right? R to R interval is being calculated. I'll just show you the heart rate, how to count the heart rate, but coming towards the leads of it, this is the basics which I have already explained you guys, right? The basics of ECG, SA node contraction, both atrium contracts, there is generation of P wave. I'm not going to read this stuff because we don't have enough time. I have already explained this. See this. AV node contraction, no chamber is getting contracted, delay of the impulse at AV node, so PR interval is getting generated, right? Ventricles contraction, what is ventricular contraction? Means QRS complex is getting generated, right? Repolarization after the contraction of ventricles means there is relaxation, right? S and T waves are getting generated. This is the basic which all we all have studied in our pharmacy college. So now coming towards the leads. How are the leads being attached and what are the leads, right? So leads of ECG. There are like uh, chest leads, right? So there are 6 chest leads. V1 to V6 are attached on the chest. V1 to V6 leads are attached on the chest. Limb leads means upper limb and lower limb. 1, 2, and 3. These are the limb leads, right? Upper limb and lower limb included. Limb leads. Augmented means the 3 corners. The 3 corners means augmented. So AVR, AVL, and AVF are the augmented leads. So just remember this stuff. After this, I'm just taking towards you that towards you guys that what are the anterior leads. Anterior means in the front of the chest, exactly which are visible in the front of the chest. So V1 to V4 are the anterior leads. What? V1 to V4 are the anterior leads. Then lateral means left side or sided ones, right? So V5, V6, 1, and AVL. V5, V6, 1, and AVL are the lateral leads, right? And inferior means downwards. So 2, 3, and AVF are the interior leads, inferior leads, right? So if you guys don't know the leads, then you guys might be finding difficulty while interpreting the ECG. So the leads are the most important stuff to being known if you are interpreting an ECG, right? So anterior leads once again in front, V1 to V4, lateral leads means side leads, like left sided leads, V5, V6, 1, and AVL. And then comes the inferior, means the downwards leads. So they are 2, 3, and AVL. Coming here, as you can see, this guy is standing in front of you. This would be a clear example. You guys might be knowing that you guys can find it easier. See, now be with me, guys. Right now, this is AVR, right? As you can see, my cursor. This is V1. V1. Here it is V2, V3, and V4. These are the anterior leads. As you can see that they are in the front of the chest, right? These 4 leads are the anterior leads. Yes. V5, V6. This is V5 and V6. 1. This LA is 1 and AVL, right? 1 and AVL. So these are the lateral leads. Now coming towards the inferior leads, mean downward leads, right? So 2, 3, and AVF. These are the inferior leads. Okay, these are the inferior leads. So coming here, chest leads means anterior part. V1, V2, V3, and V4. Okay. Then comes the lateral side, lateral part. V5, V6, 1, and AVL. Coming down towards inferior, 2, 3, and AVF. These are the leads of ECG. Augmented means corner. Now you guys might be knowing that what is AVR. If not, then I will be explaining that AVR should always be negative. Negative means why negative? Because the generation of impulse is getting started from SA node, right? So SA node is directly attached. Like I can say that AVR is attached as a SA node, right? So AVR should be negative because as I'm not good in physics, but I can say that this basic stuff of physics is like when the impulse is getting generated, that part is always negative, right? When the impulse is getting generated, that part is always negative. So means that from AVR part only the electric impulse is getting generated, so that should be negative. Don't get panicked, I would be explaining that why and how it is looking like negative. Okay, so this is the basic understanding which I have created by drawing the linings. So don't go through the drawing, it's not very good. Yeah, this is AVR, it is negative, right? V1, V2, V3, V4, anterior, V5, V6, 1, and AVL. These are the lateral. V5, V6, 1, and AVL are lateral. 2, 3, and AVF are inferior, right? 2, 3, and AVF are inferior, means downwards. Once again, how to do the interpretation of ECG. Whenever you guys are looking at the ECG, right, you need to go through this stuff. If you are following these steps, means you are going in a correct pattern and you are following a right pattern, and the diagnosis would be right if you are knowing how to interpret, right? So this is the stuff. Means first go with the order only, right? Go with the order. Identification means we all are knowing that we are identifying ECG only, right? Not any kind of chest ray or CT scan, right? Chest X-ray or CT scan. Okay. So identification means it is ECG only. Yes, it is ECG obviously. And second comes AVR should be negative. Write down the point. If you guys are attending this session, just keep the note, right? AVR should be negative. Then comes the rhythm. Rhythm, regular or irregular. I'll just explain what is how to see that the rhythm is regular or irregular, right? So comes the fourth one is the rate, means heart rate. What is the heart rate? From heart rate, which we are knowing that we can interpret that the patient is suffering from bradycardia or tachycardia. Okay. Then comes P wave with PR interval, right? If any kind of abnormality with the P wave, we can identify by looking ECG, right? Then comes the QRS complex, ST segment, where we can identify that the patient is suffering from myocardial infarction or not, right? T wave, excess, and blocks. This is the pattern which you need to follow while interpreting the ECG. Whenever you are starting to interpret the ECG, always follow this. Don't get panicked that I'm not following the timeline or something. But if you follow this pattern, I assure you guys that the timeline would be how much, but your interpretation would be correct, right? Whatever your timeline would be, but the interpretation would be correct if you are knowing how to do it. Okay. Yeah. So comes right now, this comes that heart rate and rhythm. How to know that the rhythm is regular or irregular. Okay. If the rhythm is regular or irregular, I'll just come up you with guys with the ECG. Just don't get panicked while seeing the ECG. Okay. This is the first pattern of ECG. Just be with me, guys. uh just look down towards the cursor. As here the cursor is at V5. So this is the R wave of ECG. R wave of ECG, right? Of V5. R to R wave distance. R to R wave distance need to be seen. If It is having a particular consistent gap, right? Consistent gap. This gap is consistent. That means the rhythm is regular. R to R wave interval, RR interval, we say that it should be consistent. The gaps should be consistent. If it is inconsistent, that means the rhythm is irregular. But in this ECG, it is showing that the R to R wave interval is totally consistent, right? As we can see that, see this, look at my fingers here, right? This is the consistent pattern. No, whatever the R wave height would be, right? If it is enlarged, if it is getting deducted, right? It is shortened up. Don't worry. But we need to check what are the distance gap, like the consistent gap are maintained, whatever it is, right? So here this is, right? These are the consistent gap, right? So rhythm is regular. If I say that, how do we come to know if the rhythm is irregular? Means this is the pattern. Here, see, look at my finger. Here it is consistent gap, and afterward it is getting delayed, enlarged. The gap is getting enlarged, increased, right? So this is irregular pattern. So after looking this ECG, you come to know that this is a consistent gap. Here from V5, see this R to R interval, the gap is consistent. That means the rhythm is regular. This is the rhythm which is regular, right? Now I'll show you how the irregular pattern looks like, right? How the irregular pattern looks like. Just a moment. Yeah. Can you see the difference? Yes or no, guys? Is this regular? Is this regular? Oh, okay. This is irregular pattern, right? So first step done, first task done, that how to identify that the rhythm is regular or irregular. Can you say that this is regular or irregular? Anyone?
Irregular.
Okay, irregular. Why? Because there is consistent gap. No consistent gap is there because fluctuations are there. Not any fixed time for R interval to get generated, right? So this is irregular pattern. So what is the importance of this, right? Regular and irregular pattern we come to know in arrhythmia, specific arrhythmias. Atrial fibrillation. Fibrillations means shaky, right? Shaky things. Even in the heart blocks where QRS intervals are getting dropped down into that stuff also, but it is too much long. We are only covering some part in 1 hour, so I'm not having that much time to explain you all of the things in detail. The thing is that this is the pattern which we have to follow, that while looking towards the regular and irregular pattern of heart rate, heart rate, right? So now coming towards the most uh, easy and important one task, that is how to calculate the heart rate, right? How to calculate the heart rate. Just a moment. So there are two formulas for regular rhythm. For regular rhythm, there are two formulas. As you can see in this slide, that if the rhythm is regular, note down, guys, if the rhythm is regular, we need to calculate. There are two methods, random and accurate. Both are correct, but always go for accurate method. Always go for accurate method. Why? Because it is little bit time consuming, but giving accurate result. As the name also suggests, accurate method. Random method is also good, but always follow an accurate method, because random might be sometime not giving the specific answer, right? So the thing is how to do heart rate calculation with accurate rhythm, right? Accurate method. So the thing is, there is a specific formula: 1500 divided by number of small squares in ECG. Little bit mathematic. 1500 divided by number of small squares. Number of small squares. Now how to see the number of small squares and big squares, right? This is the main headache wherever mathematics come. Just don't see that this, I know this is irregular pattern, but I'm showing you that how to see the small square and big squares in ECG, right? So this is the big square, one big square, one big square, right? One big square. In one big square, how many small squares are there? Total 25. See, five small square. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. This is 15 and this is 20, right? So there are 25 small squares. So like 5, 5, 10, 15, 20, 25, right? So there are 25 small squares here in this big squares, right? So I will say that this is the small square which we are counting here. One, two, three, four, five small squares. So the thing is that from R to R interval, R to R interval, 1 hour to second hour interval, how many small squares are coming? Not in one big squares, just we have to follow the horizontal pattern, the linear and the horizontal pattern. See this cursor. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23. So here are total 23 small squares are coming when one R wave is getting generated, and after the next R wave which is getting generated. So there they are covering 23 small square distance here in this ECG. So here total 23 small squares are there, right? And 1500 divided by 23. This is the formula for accurate method. I'll show you that how to count the heart rate of a regular. This is, can anyone say this is regular or irregular? The rhythm is regular.
Regular.
Okay, regular. So coming towards the formula of regular pattern, how to count the accurate pattern, right? Yeah. So one R wave and the next R wave is there here, right? So how many small square gap is there? See this. One. Here total five small square. 1 plus 5 is 6. 6 plus 5 is 11. So 1500 divided by 11. What is the answer? R2 R wave interval. 1 small square. 1 plus 5, 6. See 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So there are total 11 small squares. So 1500 divided by 11 is, what is the answer?
136. 136.
Okay, 136. So is the heart rate, this is your heart rate, the patient's heart rate. Is the heart rate normal or abnormal?
Abnormal. Tachycardia.
Tachycardia, right? So can anyone say that how to know that the patient is suffering from tachycardia or bradycardia? What is the normal heart rate of a patient? What range it lies?
72 to 80.
70 to 80. You are saying that heart rate, the heart rate rise like relies between 60 to 100. If it goes below 60, then it is bradycardia, and above 100 and tachycardia, right? So this is the stuff, basic like understanding about the heart rate, and what is like actual range of a normal person to maintain the heart rate. But yeah, 60 is little bit slow only, but below 60 is bradycardia. Okay, below 60 is bradycardia. So this is the regular rhythm counting method. Everyone can see the ECG? Yes or no?
Yes.
Okay.
Yes.
Be interactive. Okay. Be interactive, guys. Okay. This is the ECG, right? Can anyone say that the rhythm is regular or irregular? Regular or irregular pattern? Fast.
Regular.
Okay.
Regular.
So how to count the heart rate here? Can anyone count a heart rate for me? How many small squares are there between one R wave to next R wave generation? Follow the horizontal path. See, as I can see little bit with my naked eyes that 1, 2, 3, 4, 5, 4. Here it is 4 small square, 5, 5, 10, 11. So this is 15 small squares are there total, right? 15 small squares. So 1500 divided by 15 is
100.
100 is your heart rate, the patient's heart rate, right? If we need to follow, just a moment, yeah. In this ECG only, I'll just show you that how to know that the how to calculate the heart rate from a random method, right? Random method. So number of like 300 divided by number of big squares, right? 300 divided by number of big squares. As you can see this here V3, here V3 is there, right? See the R wave here. Here is the R wave, right? When you are seeing the R wave, the first R wave is here at exactly at the midline, right? And the next R wave is at the midline, right? So here we can accurately say that there are big boxes covered, three big boxes, right? Three big boxes are there, right? So what is the formula for random? 300 divided by 3 is 100. That is also the same answer, right? But for the random method, we need to find the R wave exactly at the midline of the box, right? At the midline of the box. So in every time in ECG, while interpreting the ECG, it is not that we are finding R wave exactly at the midline, right? So always go for accurate method. It is my suggestion, and every person is doing that only. Okay, whenever you guys are checking ECG, and don't follow the pattern where ECG is written that heart rate is this much and all that, right? Sometimes it might be negative, right? The result might be negative. Yeah. So the point is, I was showing that how to see the AVR is negative or positive, right? Negative means, as you can say, that all positive sides are above, and negative means inverted. If you see that AVR is positive, that means the leads are attached in the wrong position. The V1 leads or interior leads are attached towards the AVR part, and the AVR part is attached towards the interior part. That is the stuff which is always being carried out by the nursing practice. Sometimes it is possible, but right now they are also experienced, right? But previously there are some scenarios, and right now also there are some scenarios getting down towards the hospitals that AVR is positive, and I don't know what is the result, but AVR, if AVR is positive, then exchange the leads, right? Exchange the leads. The thing is that AVR here is negative. As you can see, the P wave is totally inverted. Here, see the AVR. P wave is getting inverted. P wave is totally inverted here. That means it is negative, right? Here it is, the R wave is also downwards. So always check that AVR is negative. Yes. Then go for the rhythm. Rhythm regular or irregular, regular. Then follow the heart rate pattern. We have to go for accurate pattern. Now, how come if I say that the patient is suffering, the patient is showing irregular pattern, the heart rate or the R wave is irregular? How to count the heart rate of that patient? If the patient is having the ECG diagnosed by the doctor and the RR pattern interval is irregular, how to find the calculate the heart rate of that patient? It is simple. Just write down the formula which I am saying. I haven't mentioned in these slides, but the thing is that number of R waves, write down number of R waves in 30 big squares, in 30 big squares into 10 multiplied by 10, right? Number of R waves in 30 big squares multiplied by 10. I'll just show you how to go for that. Okay, this is the irregular pattern. Always go for the continuous part. This is a continuous part as well, right? So just a moment. Yeah, this is the perfect one. As you can see that there are 30 big smalls, the big squares. Just a moment. 30 big squares. Count down. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. These are 30 big squares, right? 30 big squares. How many R waves are there in 30 big squares? Count down with me. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 10 R waves are there in 30 big squares. So 10 into 10 is 100. So uh, number of R waves in 30 big squares into 10 or multiplied by 10. So 10 into 10 is 100. 100 is the heart rate, right? This is the formula for irregular pattern. Got it, guys? Everyone okay with the heart rate? We have completed how to calculate the heart rate from ECG while interpreting the ECG. Okay. Just moving down towards the new topic, that is the P wave with PR interval. We have covered this much topic. AVR should be negative, rhythm is regular, irregular, rate, heart rate means. Okay. We have if the regular rhythm is there, we have to follow two methods, random and accurate. If the rhythm is irregular, then means 30 big squares method, right? Number of R waves in 30 big squares into 10. Okay, now coming towards the P wave with PR interval, as this topic is going little bit up. Okay, so P wave with PR interval, it suggests what is P wave suggesting? Can anyone tell? If we are looking for P wave, then what kind of abnormality we are looking for? What specific abnormality we are looking for? Which chambers? Which chamber like abnormality we are looking for? Anyone?
Atrium.
Okay, atrium. We are looking for atrium abnormality. Okay. So atrial abnormality is just like we are looking for P wave. Okay. If the P wave, the normal P wave size is just like one small square. I'll say that just one small squares is the normal, 1 to 2, right? One small square is the basic size, right? One small square is the basic size of the P wave. One small square, not big square. One small square. If it goes above one or two, above one, like two or two and a half, something like that, that means the atria is getting enlarged. Atrial is getting enlarged, means atrium. There is enlargement of the atrium. That is known as right atrial enlargement. Right atrial enlargement is there, right? That means uh, there is hyperplasmic situation getting developed in the atrium, right? This is basically seen in the COPD patient, right atrial enlargement. Right atrial enlargement. It is also known as core pulmonale. P pulmonale, core pulmonale. Okay. This is the basic stuff which we all are looking for. Right atrial enlargement. If the atrial size, like P wave size, is getting enlarged than one small square, right? It is covering 2, 3, right? That is known as right atrial enlargement. Uh, if you have seen the P wave, normal P wave, it would be smaller one. But if the P wave height is enlarged, you might be able to see in the ECG. I am about to show you that ECG as well, right? But note down that if the atrium enlarged, right, there are some situations getting seen whenever there is atrium getting contracted and enlarged. That means the patient might be suffering from COPD. There is atrial enlargement as well, and might be core pulmonale might be the most of the commonest reason because of the atrial enlargement. So you need to check out for the patient's chest x-ray as well, because in that stuff you can see the hyperinflated lungs if you are interpreting right atrial enlargement 70 to 80%, right? 70 to 80%. P pulmonale is also known as core pulmonale. Okay. The thing is that if you can see, I'll just show you the ECG only right now. Okay, the first ECG only. And the thing is that whenever you are looking, one more thing, whenever you are looking for the atrial enlargement, right, for the P wave, specific P wave abnormality, you need to check for two leads only. Which two leads? Lead 2 and lead V1. Lead 2 and lead V1 are showing better morphology of P wave. Lead 2 and lead V1, right? Whenever you are going for P wave checking, always look for lead 2. This is the lead 2, right? This is lead 2 and V1. Always check for lead 2 and V1 for P wave abnormality. If you are checking that the P wave is in the correct direction or not. So, starting from the point, right? AVR negative or positive? Anyone? Or sorry, negative or positive? Yeah. Is the AVR negative or positive? Anyone can say?
Negative.
Okay, negative AVR. Done with the first task. Second point, rhythm regular or irregular? Is the rhythm regular or irregular in this ECG?
Regular.
Regular.
Okay. Okay. What is the formula for regular rhythm heart rate? Formula. I want fast formula. There are two
1500
formulas,
by number of small squares.
and the random one is
300
300
by number
divided
of
by
big
number
squares.
of big square.
okay. Number of big squares, right? Done. So here we can say that I don't need you guys to count a heart rate, as you might be getting the answer. It is good one. So here coming up, that is after that P wave is coming. Is there any abnormality seen in P wave? P wave is normal. What is the normal height of P wave?
One small
One
square.
small square.
Okay. Is it covering one small square or more than that?
More
More
than
than
one
that.
square.
I'll just zoom it for lead 2, right? We need to check for lead 2. As you can see here, it is covering 1, 2, 3 small squares it's covering, right? So it is getting enlarged here. This is normal. No, it is not normal. It is abnormal. So this is showing that the patient is suffering from right atrial enlargement, right? Right atrial enlargement might be the reason that patient is suffering from code pulmonale as well. So whenever we are checking for right atrial enlargement, there are two things to be checked more. We need to check for right ventricular hypertrophy as well as if the patient is suffering from pulmonary embolism. Okay, I'm not showing that how to know that right ventricular hypertrophy or pulmonary embolism, but the thing is that always check for that. These 2 points need to be noted down. Okay. So with right atrial enlargement, the patient might be suffering from COPD. It is also known as code pulmonale, P pulmonale. Okay. Now coming towards the left part, how does the left part looks like? This is the left part, right? The right part gets enlarged. The left part is making M-shaped notch. As you can see that if a patient is suffering from left atrial enlargement, and during that point in the P wave, there is M-shaped notch. M-shaped notch is there, right? This is M-shaped notch as it is showing. Left atrial enlargement, M-shaped notch is there, right? This is the M-shaped notch. It is showing left atrial enlargement. That means whenever there is specific left atrial enlargement seen, if P M-shaped notch is there in the P wave, that means there is some kind of valvular dysfunction. It is also known as P mitral, right? P mitral or valvular dysfunction patient is there, right? Patient is suffering from any kind of valvular dysfunction. So left atrial enlargement means M-shaped notch is there, M-shaped notch. And right atrial enlargement, height of P wave is getting increased more than one small square, means greater than 2, 2.5 or something like that, right? Here, M-shaped notch for left atrial enlargement. And specific leads to be checked for P wave abnormality is lead 2 and lead V1. Okay. Okay, this is the ECG. Come up with me, guys. Just be with me right now. AVR negative or positive? Just check the P wave. If it is inverted, then negative. If it is above, then positive. Is the AVR negative or positive? Fast.
Negative.
Okay, negative. Rhythm regular or irregular? Rhythm is regular.
Regular.
Okay, regular. Heart rate, I don't want to calculate. Just come towards the P wave. Which leads we are checking for P wave?
B1 and
Lead
2.
2.
Lead 2 and V1. Okay. So here, if lead 2 we are checking, uh, as you can see, the P wave is here. Any kind of abnormality is denoted by you guys? Is
M
there
shape notch.
M-shaped notch is here, right? This is the M-shaped notch. M-shaped pattern. M-shape. So it is clearly indicating that the patient is suffering from left atrial enlargement. M-shaped notch is there. Left atrial enlargement. This means that there is some sort of valvular dysfunction here in the patient's ECG. Okay. One more stuff last upon. How about this ECG? AVR negative, positive,
Negative.
rhythm regular, irregular. I guess only 2 to 3 students are interactive. I can't see any students
Regular.
interacting. Okay, regular. Okay, here it is regular rhythm. Okay. Now coming towards the P wave abnormality. Is there any kind of P wave abnormality here? From the naked eye, we can see that
Yes.
enlarged or M shape.
M shape.
Everyone M shape or enlarged?
Enlarged.
It is the reciprocal changes. Yeah, it is enlarged, not M shape. M shape means it is totally showing here M shape or here, right? But here it is enlarged, just like a cap top, right? Cap top, just like a cap top. It is getting enlarged here. This is clearly indicating that the patient is suffering from right atrial hypertrophy. Okay, don't get confused. Yeah, you guys are doing great job. But nice pick. Whoever answered it is enlarged. Okay, sorry. So the last point here for the P wave abnormality only, Wolf Parkinson White syndrome. We also say this point as delta P wave, right? Wolf Parkinson doesn't mean that the patient this is of Parkinson disease. No, it is not like that. Okay. Here the thing is that the PR interval here, the PR interval is not getting present. Like it is not not being seen in this ECG, right? In this ECG, if the patient is suffering from Wolf Parkinson White syndrome, there is missing of PR interval. Okay, so here it is the P wave and the R wave. So the P wave is directly getting generated with the QRS complex. This is the P wave and the QRS complex. So P wave and the QRS complex, it is directly getting generated. P wave is directly getting generated with the QRS complex. That means no PR interval is there. This is the case of Wolf Parkinson White syndrome. It is really very rare right now. I'll just show you how it looks like. See, this is the case. No PR interval is there. The P wave is directly getting generated with the QRS complex. This is the stuff of Wolf Parkinson White syndrome. Okay, Wolf Parkinson White syndrome. Now, how it looks like here, this is the normal electric pathway, how it is getting generated: SA node, AV node, bundle of phase, bundle branches, specifically left, right. left anterior fascicle part, left posterior fascicle part, and down to the Purkinje fibers. And after that, it is getting recycled once again like that only. But in Wolff Parkinson White syndrome, the thing is that the AV node is just like a gatekeeper. It makes the delay. Just consider one example. I'm always giving to this my student. Like the thing is that AV node is just like a gatekeeper. Whenever the extra impulse is getting generated from SA node and traveling towards the AV node is like panicked that this is extra impulse. I need to block down my gate. He is just like the gatekeeper. Whenever you guys are entering in the college, right? There is a watchman there, specifically college or university, right? They need to check your ID card or some kind that you are always coming to the college. Watchman might be familiar with you. Yeah, you are the right person to this college. You can go right without the ID card as well. But the thing is that he's always checking the ID card. Need to check that ID card and see that the particular student is available for the uh, college or not, like specific student is there or not. Okay, he's studying in this college or not. The thing is that the extra impulse is getting generated, so AVR is like, oh, these are too many impulse coming at a point. I can't manage this, I'll stop all the impulse. So AVR is blocking the impulse. But God has given the electrical impulse and our heart, right, inside our body to maintain in the incorporated stuff, right? So it's always been there are some sort of parts getting generated when one gate is closed, another part is always getting opened for us, right? This is the accessory pathway, right? Your friends are there, right? If you are not having the ID card and watchman is also not knowing if you are studying in the college, right? You are always getting panicked that I need to attend this exam. If I'm not able to get entry in the college, then how should I get the exam, right, done? So there is a like, so your best friend, this is the accessory pathway, right? He or she tells you that climb the wall, right? Climb the wall, backside wall of the college. So this is the stuff which accessory pathway is taking up. Where AV node is blocking your impulse, accessory pathway allows that impulse to travel back further, right? So due to the blocking of the AV node, there is no generation of the PR interval, but the accessory pathway, your specific bundle of Kant is there. Bundle of Kant. From that, the impulse are getting generated and then carried down further towards the Purkinje fibers. So it's always giving that stuff only, but only the PR interval is getting missed because of the blockage of the AV node. AV node is not blocking. This is the reason. While it is really very rare right now, it is also known as Wolff Parkinson White syndrome, not a delta wave. But the thing is that when I have like heard about that, when a small infant or small child, baby child is born, during that phase, he or she is in the womb of the mother. So that environment is specifically suited for him, right? Whenever he comes in this like world, right, the environment, surrounding environment is not suitable for him, right? He need to manage the breathing sense of him, right? The breathing sense develops sometimes fast slow. During that point, this situation happens. Bundle of Kant, Wolff Parkinson White syndrome. Okay, this is the accessory pathways generation and giving the impulse generation. Okay, this is the delta wave, how it is looking for P delta and Wolff Parkinson White syndrome. Okay, so thank you so much, guys, for the session.